Thank you so much, and thank you for the opportunity to speak. I'm a bit humbled by the audience, who I think could probably do the slides better benefit than me. But anyway, I will press on. I'm speaking to you from Sydney, and I think a large proportion of the audience are on the east coast of Australia. I'm in Gadigal country of the Eora Nation in Sydney, and acknowledge the elders past and present and the contribution they make to our society. So without further ado, let me just share my screen and share the sound, because we've got one, and I'll just confirm that that's working.
Yes, we can see it well, Dr. Mike.
Okay, thank you. So it's now the 110th day, I think, of lockdown for those of us in Sydney, so we've had a bit of time for reflection on where we are and what might be needed. And my particular bent is obviously digital transformation, and I've been working to deliver universal care, which we'll talk about over the course of the presentation. So just the disclaimer, this is me in a personal capacity. I'm not talking on behalf of any of my employers, current or past, and just want to try and explore some of the things that are going on. So this is a view of a GP who he computerized his surgery in 1982. And I came over here 10 years ago to do a skills transfer project, still largely waiting to do that skills transfer. I'm finding Twitter quite interesting at the moment for a number of reasons. One of which came up the other day from Shannon, just moaning that she can get the U2 album on her phone, but she can't get medical records on her phone. And I think that's observation that our social media, with the exception of Facebook and WhatsApp and Instagram, at the beginning of the week is largely in advance of our clinical systems. Interoperability is kind of normal. We can drag things in and out of things and they all just work. And we can't import a record into our clinical systems, but the Gartner hype cycle is talking endlessly about blockchain, about artificial intelligence, and all sorts of other fascinating things. But we are still struggling across a number of nations to get the basics in. And if we look at where we were a decade ago when I got here, we had proprietary systems, certainly in general practice, were proprietary terminologies. We had billing systems predominantly. Usability wasn't great. Interoperability was limited. Secure messaging was one of these things which was coming real soon. We had a low maturity of the digital workforce, and professional standards just didn't meet up with technology requirements. And those of you who will know me will know that actually I think a lot of those challenges are still there. We have made not a lot of significant progress over the last 10 years. I'll talk about some of it, but in terms of semantics and real interoperability, we are still very slow. And an old slide shamelessly reused, paper is the problem. One day in one diabetic clinic looks like that on the left hand side. One morning's guidance for the problems that came to a GP looks like the picture on the right, and both of those are insupportable. A single patient record in outpatients on the left there is unable to be examined in any realistic way, and even when you try and transfer a paper record between one EPR and another one, until very recently you had to print it out, and that's the output there. So I think all of us on this call would agree that the future of health has got to be digital. We've got to move away from the paper as soon as possible, And we've got to do it as a matter of urgency if we're going to get the benefits of personalisation, precision, and AI decision support and all of that good stuff. And the question, therefore, is, are our member countries here in AeHIN ready for that challenge? And what are they going to need? What are we going to need to make that digital challenge? We all know from trying to implement systems that healthcare is a complex adaptive system. It's an ecosystem which avoids change at all costs unless there are real benefits shown. And policy funnels tend to regard it a bit like a brick that you can buy some bricks, you can get people to throw bricks, and you can see where the bricks are going to. Healthcare is more like a pigeon. If you throw a pigeon, you don't know where it's going to land. It's complex, it's adaptive, and the way to get a pigeon to go where you want it to is to put some seed down. And the new methods that we need to get things to happen are based in some of the new technologies that I'm reading about at the moment in Frame Innovation, which is from Kees Dorst here at UTS. And again, just how we get from the spaghetti of today to functioning semantically integral systems is vital for all nations in the region, whether they are low income, medium income or high income. They are all the same problems, which I assert are going to be able to be solved by the same thinking and tailoring of the approaches. So Mirror Mirror, for those of you who haven't read it, there's a link there. That's the updated version. It hasn't changed from the last edition, where percentage of GDP is inexorably rising, with America leading the charge, and the high spending nations there on the right going from between 4 to 10%, but always on the rise, and quality doesn't necessarily follow that spend. So my view is this is a time where change is needed. The COVID stresses that have been seen on the systems, and my work during the early COVID stage about getting even simple data out of clinical systems so the spread of the virus could be well documented by WHO, involved scraping PDFs, begging for Excel spreadsheets, and just trying to mash data together. And we really could be doing better than that. Technology has been there now for 10 years. All of the technologies we need are there. Magical thinking about putting a box on a desk and expecting that to solve a problem has got to go away. Organizations whose main purpose is to make profit will not solve these problems, and therefore it's up to us who are in positions of leadership to solve the problems. Recently we've seen the Australian progress in the My Health record, a shared record for all of its citizens, the electronic prescriptions, which I'm in receipt of at the minute, having been mown down by an electric bike on a pedestrian crossing, work very well, and getting things connected is beginning to happen. But that's now the source of another strategy which we are currently in consultation phase about. So there's a lot of doing things over and over again and repeating the same trials because they weren't done in one country. And I finally learned that Albert Einstein didn't actually say this. It was actually at the World Service Conference of Narcotics Anonymous. So that's my little contribution to social media tonight, that we do need to do something different. It is insane, but Einstein didn't say it. So, Julian Tudor Hart, who I had the pleasure of meeting early in my career, coined the inverse care law, which basically says that the availability of good care varies inversely with the need of the population it serves. The second, not so quoted bit, the market distribution of medical care is a primitive and historically outdated social form, and any return to it would further exaggerate the maldistribution of medical resources. It rang very well with me as I was looking at it. So that was 50 years ago. A lot of health services are still in that position. And lots of big data, lots of claims about big data, and a lot of the attempts that I've seen over the COVID period prove that big data is not there yet. So just winding back to where I started, which was in general practice in the early 1980s in the UK, and we had card indexes, and eventually it took me a while to find a picture. We used to use these notched edged cards to actually run our age, sex register, our population register, and also find our common diseases. And you pulled the people up that weren't in it, and the people that were left behind were the people you wanted to see. And if you dropped that pack of cards, it took hours and hours and hours to put it back together again. But that's where we started in the 1980s. In 1981, when I was a trainee, my trainer got a Southwestern Tech system. That was it. I had to help him with the soldering iron to actually put the keyboard together, because this was before keyboards were standardized, and we had to buy the right keyboard and then solder it together. And then a couple of years later, we had our first real system, which was a Unix-based system, and it kept structured, coded records according to the Larry Weed principles. And this is the demo system from 1985. The JR is actually James Reed, who was one of the fathers of SNOMED, and that was our system, and it was reasonably fit for purpose. We ran 16 users on a 286 machine, and we had code, we had structures, and we had analytics. And that principle of giving the users back data has been one of my strong selling points across the years. Of don't just get people to enter data. They don't like being used as data sponges. Take the data out, but don't give it back. Give them back the data in an analysed form. So I've been standing and luckily mentored by a number of giants, from James Reed to William Pickles and Larry Weed. And I recently bought this document, which is William Pickles' Epidemiology in Country Practice. He wrote this in 1939 and became 20 years later the first chair of the College of UK GPs. And again, just through his data network, which was the school teacher, the clergy, and his family, created these lovely graphs of epidemics that were happening in his valley in the north of England, an isolated valley in the north of England. And just this one as an example here, where the schoolmistress fell ill on the 9th of January and the cases that followed from there. So again, I wanted to buy the book because reading a book from 1939 on a Kindle didn't seem the right thing to do. So that's one of the people's shoulders I've stood on. The other one is, of course, Larry Weed, and just a reminder of his insight and expertise on coding.
this is not an idle discussion of little technical bookkeeping details. The practice of medicine is the way you handle data and think with it. And the way you handle it determines the way you think. Once you get over a period of time with multiple variables, the very structure of the data determines the quality of the output. And this is what's so hard for medicine to accept.
So that's from 1971. This is what's so hard for medicine to accept. And we are probably not that far away from that. Though I have seen some movement recently. And these are a couple of quotes from his seminal 1968 paper, Medical Records that Guide and Teach, where he says, the organisation of the medical record should be a matter of immediate concern to the practicing physicians and students, because developments, he was talking about computers, are far more advanced and immediately applicable in 1968. And yet we are still in this peculiar situation of thinking that we can put data into lakes and get data out. Now, if you go fishing in a lake, you might get a fish, but you might get a shopping trolley, or you might get an old boot. And there's a lot of money being spent and has been spent already by the big boys, and recently, of course, Google has given up again on dismantling its health division. Health Vault lasted longer than Google Health the first and second times round, but we can't afford to keep throwing money at a problem which needs solving properly. And I'm not blind to the implementation problems. Going back to that picture of the man with the spaghetti of cables up the pole. Existing architectures are complex, they are difficult, but we've got to start somewhere, and we've got to start building ecosystems and move away from doing individual projects to get data which allows nation building across the region. And my assertion is that many of these modules are identical no matter what the income of the country is. There are different ways of doing that, and I'll talk in a couple of slides just about work that I'm currently doing in Rwanda and Burundi, where we are implementing a full fire and SNOMED based system and getting results in rural Rwanda, and that's a full system which is also in use across New Zealand. So I'll talk about that in a minute anyway. And again, analytics. If we're going to do analytics, let's actually not do atrocities like this. This is another one from the COVID epidemic, where someone was trying to prove how badly New South Wales was doing in comparison with Victoria. I'm not going to go into how many atrocities have been visited on that particular graph, but it's a lot. So the one slide to take home, if you have no others, is just we've got to get these things on the right of the slide across the region and stop duplicating, stop failing, or if we're going to fail, all learn from that failure. Get leadership, both technical and clinical. Get a communications infrastructure in place suitable for the purpose, as I'm sure all of you during COVID have tried to have, and I tried to have a conversation with someone in Canberra today on a meeting, and we gave up after 3 attempts. We need communications infrastructure which are appropriate, and how those are built I'll talk about towards the end. We need supply chain, not only for stamping out fraud, but also making sure that cold chain is adhered to, and all of these things can be built in to a proper record system. A simple population database, births and deaths, and where are those people living, is important for every bit of planning. And we found recently in the COVID epidemic that those information weren't there. Have a unique identifier and use it is another important lesson. Workforce, as I've said, data quality, structure, coding, and if you can't have usable systems, then you can't get decent data quality. And remembering that clinicians are busy and they are about relating to the ill person needing care in front of them. They are not interested unless the computer or the system around the computer is usable in the disruption that it brings. And it's only through showing how benefits are realized that that is going to be delivered. And again, we could have a long discussion about usability. I've worked on a number of projects. We are looking for a new home in academia for the common user interface deliverables from the NHS project at the minute. And I'm talking to you, Vic, and Pittsburgh and a couple of other people about how that could be hosted. So we may have some offline discussions about that. We know, especially in America, that the amount of documentation is burning, or the requirements for documentation is burning people out, burning clinicians out, and we've got to work out how we can get better with that. Again, just another little Twitter example. 1 hour and 40 minutes that Gordon spent just trying to get his clinic patients in a form that he could practice modern medicine in. If there was an interoperable record, that should be part of the furniture. So just underlining that we need to know our population. Stable denominators allow all of the analytics, all of the planning to help, but only if you are trusted to hold that data on behalf of your population. Integrate with your communications infrastructure. Every time you build a road, every time you build a tunnel, every time you build a bridge, can communications infrastructure be taken somewhere novel? And at the same time, power and backup power, solar, wind, all of that, as well as reliable power, because trying to do it without that is very difficult. And finding that in rural Rwanda, but we're using solar powered backpacks at the minute. Seems to work fine for charging an iPad. Standards right from Larry Weed's time needs to be put in place. It needs strong leadership that understands why it's important, and it needs a whole workforce development, clinical and technical, to be put in place, and that needs to be supported through a deep understanding of interoperability, semantics and security. And I know the audience here understand that. But we've got to start this at our medical schools, nursing schools, pharmacy schools, because this is not just something that creeps out at you. And AI, precision, personalization, lovely, very exciting, very shiny. Recent announcement today here about lots of money that's going to be put into it. But unless we have the backup of high quality patient data, it's going to be very difficult to bring that to the point of care and the point of need and actually drive the precision and personalization agenda. So heading into the last few slides here, we need to pick things up from the experience of us all in the region. I think there's something to be done around data sovereignty, and I'll talk about that in a second. Obviously, security, privacy, and trust is massively important. We've got all of the standards we need now for the structure of records. The SMART guidelines that the WHO have just produced for maternity care and childcare, and are going to be doing for HIV and a whole bunch of other things in the near future, are very exciting, and they're all HL7 fire based. The coding of data in a granular enough form to allow us to practice as clinicians is vital, but we need clinical systems that do that, and we need to do it as few times as possible. So with that in mind, I've been working between New Zealand and Burundi and Rwanda, and actually putting iPads in the hands of community workers in the rural settings, and they are doing maternity care and child health. And we have gone from the point of where they are walking around with 16 kilograms of paper to walking around with a backpack with a solar panel on the back and an iPad to collect their data. And these are very low qualified people, but they are now being supported by basic decision support using a structured and coded HL7 SNOMED record. So if we can do it there, it can be done anywhere. I've put a link there to the video, and there is going to be a session on the 28th of the month at the SNOMED Expo on that, and it's 6:30 UTC, so I'll let you work out what that is in your time zone, but I'd thoroughly recommend that. So just coming through to the final bits, as consumers, I think we're going to start voting with our feet. My banking, my flight bookings, my check-ins, most of my shopping over the last 110 days has been done online. Coding and terminologies existed for decades. Some of it was written by me, and it's not in general use. There's a lot of squabbling across the region about secure messaging, and we're still passing PDFs around rather than structured coded data. Now, I don't expect perfection by tomorrow, but it would be nice to see progress towards that. Because if we're going to get to this precise and personalized world, then I'm finished with quality and safety. I think that should just be a foregone conclusion. We've got to just have that built in. But that does mean that medicines, allergies, diagnoses, problem lists have got to be available to the people who are caring for me. And where my data is currently still fairly difficult. We don't own it. We don't control it as citizens. It's very unlikely we can share it with ease. And as we've been hearing in the last few days, people profit from our data, and whistleblowers are beginning to start getting emboldened. And if we could profit from our data, that would be nice. So I think it's a food chain problem. Clayton Christensen, if you've not read his books, both on the medicine stuff, but also his more general books, he sadly died recently, he talks about disruptive innovation. And if we're going to get disruptive innovation, normally it starts with the small furry animals and moves up the food chain. But at the moment, at the top of the food chain, we've got some large furry animals who are very happy at the top of the food chain, and innovation is perhaps not their prime consideration. So in the region, we've got some really massively important things. We've got SELA, run by Philip and supported by ADB and others currently, and that's providing training, teaming, tooling, testing, and perhaps terminology in the near future. In the near future. And I think that is a massive plus for the region. And Africa are looking to me to see whether they can help and be brought into that. We've got the IPS, and again, the IPS could be a catalyst, because that would bring very strong standards-based approaches to the region and bring those pieces of information which stop me being harmed into play. So digital health in the region, we've got CILA, we've got the implementation guide which has just been produced. Now it's Pacific centric in its examples, but the three strands in it of leadership and governance, technical and analytics innovation, and just breaking that down, are universally applicable. So if you've not read that, again, I think that's a very important piece of work. So to close, the time is there. We have got to get away from just building new hospitals because they're shiny and they make ministers happy and cut a ribbon. We've got to free up primary care from this fee-for-service structure that a lot of countries have, because that doesn't seem to deliver quality and continuity. We've got to join acute, community, aged care, psychiatric care, general practice, because separating them into separate cabals with separate ministers sometimes doesn't get good and joined up things happening to me, the data subject. Clinical leadership needs to start making demands. Self-regulation in industry, I would posit, doesn't work and isn't working. We've got standards which have been recommended for years and are not in place. Integration and continuity are just not happening, and if they don't happen, then I'm at risk, and I'm increasingly unhappy about being at risk. And duplication is just a waste of time, and it's a waste of money. So we've got all the bits. We know what we want. We want universal care. We want better care. We want higher quality care. We want better commissioning, planning, policy. I want to see more accountability and more engagement in the process, because with that, the digital health systems of the future in the region could very quickly lead the world. So thanks for your attention, and thank you very much for the opportunity to speak.
Yes, thank you very much, Dr. Michael, for sharing your experiences and insights. To all our participants, if you have questions, please feel free to type them in the chat box. I'm also starting to enable the microphones in case you would like to ask through the mic.
It's Tang here. Cha, can I have a question? What?
Yes, please go ahead, Professor Tang.
Thanks, Mike, for great. I hope you're better from that last accident.
Yeah, another month or so should be okay, but yeah, it's a bit painful.
No, I like what you're saying, and the last slide is good. I'm just wondering how you would prioritize them, those lists of things we need to do from your experience. Yeah,
there's the basic funding organization approaches of power and communications, and it's about making sure, from my experience with some of the funders, that the road gets built, the tunnel gets built, the bridge gets built, but they don't consider the things that could be put alongside that. So there's those sort of things for low income and development countries. For the practical things, this is about us as clinicians demanding better tools, basically. It's don't make me fill in a form if you don't show me a benefit for it. Don't sponge data out of me, which is very useful for your running the clinic, running the service, planning, but it's no use to me at the point of care. And we see that a lot in all of our systems. And the ones that I was working on very early on in the 80s were developed by GPs in their surgeries. So they were very much focused on the clinical task. But then as the bigger players subsumed them, they lost that clinical focus and turned into much more administrative systems. So it's turning back round to person-centric and practitioner-centric systems. Does that help?
Yes, in principle, but I'm just thinking of the practicalities on the ground. You know, who would you knock on the head first?
So from the, I mean, you've got to start at both ends. So you bang on the health minister's door and you tell him how, or her, how much better their job will be if they are to take a route at a standards-based approach. And at the other end, with clinical leadership, we're going to have to grow, and that was the bit I put in there about medical school, pharmacy school, nursing school, because the informatics components are there, but the career of an informatician is not very clear in a lot of the region. So we're going to have to grow a workforce which understands coding, terminology, because I'm again talking to some of the LHDs as they try and build their capacity for whatever's going to happen in the very near future. They are lacking people with the abilities that are now needed to drive clinical systems harder.
Sorry, thanks, Mike. I mean, I'm sure Jeff or Kev has got other ideas to bring up. I don't want to sort of dominate.
I'm sure
take too much of the conversation. But
you and Jeff could have done much better justice to the slides.
I don't think so, Mike.
Yeah.
Hello, Tang. Good to see you. So, Mike.
Good to see you too.
Yeah. A great presentation, Mike. I really appreciate it. And I think just following on from Tang's question and comments there, you'd be aware, strategy development, there's essentially three components. And the first essential one is the current state, having a good, really honest understanding of what the current state is and then working out some sort of destination or series of destinations and then a roadmap to get there. Yeah. And I find oftentimes the current state work is underdone, and if you don't get the current state properly understood, then you're trying to build stuff on stuff that's not necessarily well defined and understood, and not connected with the present reality. So I think that also could be driven by what the country healthcare priorities are as well. So, as you know, I'm fairly recently looking at Southeast Asia, and I've got a particular interest in Indonesia at the moment. And, I'm aware more fully of, the issues with child health and, developing chronic diseases and so forth as well. And I'm aware that the health ministry has got priorities in those areas. And I'm wondering if embarking on a digital strategy that's built up on those sorts of priorities, I take your point that it's important to do multiple things simultaneously, and developing up an overall framework is essential, because you need the infrastructure components, and I mean digital health infrastructure components here, the terminology systems and standards and so forth that you mentioned. But applying them and have them build up from a focused area like children's health or maternal or something like that is probably a way to do it. So yeah, I was just curious what comments you might have on that sort of line of thinking.
Yeah, and I left the detail out on that frame innovation stuff, but that's about how you develop ecosystems which drive exactly that you've got your policy cycle, which inevitably is going to change with the people in power, but then you've also got your clinical cycle and clinical innovation cycle, and it's how you frame the interactions of these cycles so that everyone actually sees progress. Because at the moment, with a complex adaptive system, basically we just see some change coming and we root around it. They're going to try and update that, and we as clinicians naturally push back. If you look at something like endoscopy, there was a clear, obvious benefit from endoscopy very early. So everybody uses endoscopy now. You'd almost be crazy if you didn't use it as first line. Whereas electronic records, which have existed for longer than endoscopy, we're still struggling. And we're just not showing the benefits to the clinicians. And if we're not showing the benefits to the clinicians, we can't possibly show them higher up the food chain. And as we know, politicians like shiny things, but they don't like shiny things that are disappointing. And it's how we drive those things. And that's one for a very long discussion.
And we can't ignore the political dimension, and you're alluding to that, I think, in the comments you're just making. And again, with Indonesia, the embarking on introducing a universal healthcare system, from a funding and sort of insurance and payments point of view, I guess, it's really, really good. But to make it hum, it needs the co-investment in the digital infrastructure and along with that. So I guess it's about sort of progressing these fronts progressively forward together in an orchestrated way. That's the challenge for us all.
And I think it's also about aiming high. This is not about
aspiration. Yes.
Yeah, because with a lower budget doesn't necessarily mean a lower quality of software or provision. And that was certainly what we're doing in Rwanda. It's exactly the same underlying system. It runs on AWS, and it's got Fire, and it's got SNOMED, and it's just got a different set of scripts in it, but it's the same system. Rather than something that's been done to a low budget, so that the business model there is make money from the rich countries and at cost in the low income countries, and that brings the benefits to the low income countries of fully developed standards based current technology, which is a lot easier to both implement and maintain than my Unix system, which was a little temperamental back in 1982. And so again, making sure that whenever there is an implementation going ahead, it is to the highest quality, not to something that appears immediately affordable. Because I think there are ways to get the highest quality of things in place across the region, and I think there are business models that can be used to drive across the relative ability to pay.
it's interesting, your experience in Indonesia, Jeff, and the Rwanda experience also sounds interesting.
Yeah.
My own experience over the time dealing with, I guess, informatics for a long time is capacity building, and that's a big thing. I know you, Mike has been in it for a long time. I remember a long time ago, in what you were the NHS stuff, the jigsaw and all the stuff, those kind of, long, it's kind of long, been going for a long time, but we still haven't made much progress in that sense. I know, like, in terms of capacity building, I've been working pretty closely with WHO as part of the Collaborating Center on, kind of running this kind of courses, digital health leaders courses, so that we can get a cadre of people to lead the stuff, as opposed to technical people and so on, and both at HQ and in the Western Pacific. You despair, though. I mean, like, for instance, the course that's being done is commissioned out to USA. And we talk about standards and enterprise architecture and platform. But when you look at it, really, it's adding to another kind of a level, another type of standard. It's, it's like back to the old maxim of, we can talk about standards, but every time we deal with standards, we add another one to the standard. All right. So there's too much standards around. But the kind of looking, and I, on behalf of Wipro, we evaluated the course. We are evaluating a couple of courses as well in terms of relevance to the Western Pacific. We kind of the biggest problem in these courses, and there are many of these courses being run across the world in the South American and North American, everywhere else, is that there's lack of consistency in the terminology describing the concepts. This is, as opposed to health concepts or snowman and stuff, it's just the pedagogy is fragmented, as well as the actual, say, like health concepts like SNOMED. And hopefully SNOMED 11, ICD 11 and SNOMED, that kind of stuff will help along with FHIR. But in terms of capacity building, we're still adding to the fragmentation. And really, that's what, I guess that's been my mission for a while now, trying to standardize that capacity building efforts. So you really need that meta level of standardization in terms of actual practice. And the other thing I learned right from the beginning, many years ago, was data quality. Data quality, it seems to me, we develop all these flashbang shiny tools, and then when we try to get money to do it, or try to do it in a big situation like in a hospital, in Melbourne, it just didn't work because we didn't have good enough data to actually run this decision support stuff. So I've been doing a lot of data quality work now, and it seems to me that data quality is probably an easier thing to deal with than interoperability, because it is the clinician and the data collectors and whoever else is doing the data custodianship. You can work on the data quality without having to bring in a whole lot of partners, as long as you have a standard to work to. Right? But interoperability requires a lot of people to actually to work together.
No,
and no country in the world has got an enterprise architecture or an enterprise-wide platform. None at all. Not that I know. So So that's why I'm doing my little thing in data quality, where I know I can get a little bit of progress.
Yeah. But it was interesting. You mentioned the whole Jigsaw and then Primus project. I mean, that did from 1998 to 2003, we had 700 facilitators running around in UK general practice, and a whole curriculum for data and data quality. And that approach was what delivered the quality and outcomes framework. And of course, everybody got paid top dollar, which caused great consternation at the ministry, because it was meant to take between 5 and 10 years for people to get the top quality payments. But because we'd been working with them, they all knew exactly how to get the data in and how to run the systems, how to delegate the data acquisition. It's data quality, and that was over 20 odd different GP systems at the time. So I would totally agree the data quality issue is easier than the interoperability one, and it's a good place to start.
Yep. You get immediate feedback.
Yep.
To the GP or to the clinic.
And show benefit, even showing them a chart which says you are here, in a comparative set of other practices, you are here. I'm not making any judgment about this number, because it's just your data. And the first thing everyone says is, no, that's wrong. And then you have to say, well, it's come out of your system, that is your number. And then let's look at the process. And that could be, these women have had a prostate exam, these men have had a breast exam, whatever it is. It's about how that number got put into place. Or you've got a low number of geriatric reviews, but then you're a university practice, so you're not going to get them. So all of those things were part of the data quality process that we did, which drove very strongly towards high performance at the start of the quality and outcomes framework. But then, of course, the politicians decided the GPs were getting paid too much, and it all turned into a political fight, and it all went horribly wrong. But that's another long story.
So how do you deal with that? Anyway, I think it was a great presentation, Mike.
Thank you.
Nostalgic and deja vu.
Sadly, it would be nice to be able to say, look, these all started and that's when we done it all. Well, we've still got a lot to do. I'm hanging around to try and make sure we get it done.
Yes, thank you so much, Dr. Michael, and as well as Dr. Jeff and Professor Tang for sharing your insights. We have recorded this session. We hope it's all right for us to share it with the AeHIN community.
Sure, of course.
Yes, thank you so much. Also for giving us time despite the time differences. I know it's really late in Australia right now.
Yeah.
Thank you so much.
Definitely bedtime.
That's
Thank you very much. And thanks for your
and have a
comments,
good
Jeff and
night.
Tang.
Yeah.
Look forward to seeing you in person soon.
Yeah, good to see you. Yeah.
Yeah. Thanks, guys.
Bye.